Be very much useful for us. Thank you, sir. Over to Suryaprasath, sir. Thank you.
All right. Thank you, Dr. Narasimhan, for the kind introduction. Can you hear me okay?
Sir, I can
Yeah,
hear you.
you're audible, sir. Please go ahead.
Okay, thank you so much.
Yeah.
Thank you, as I said, thank you so much, Dr. Narasimhan, for a kind introduction. And special thanks to Dr. Adalarasu, who is a friend of mine from way back, like 20 years ago from IIT Madras. So my voice is kind of broken because I do have a sore throat, probably a little bit of COVID for the last 2-3 days. So apologies if I cough in between. Hopefully it will not flare up. It was very mild, so I'm completely fine. Thank you. So let me share the screen and start the session. I know this session is actually the based on digital revolution and neurodegenerative disorder diagnosis. So Dr. Adalarasu has invited me to give a talk on AI for Parkinson's disease. So I arranged my talk in a multiple levels. So let me start sharing my screen first before I talk about
Yes,
what
sir. Kindly share your screen, sir.
yeah. And also, if you have questions, please feel free to put it in your chat. Okay, so let me see. Give me 1 second. Okay, so let's see if it lets me share the screen. Okay. Share, maybe I will share the entire screen. Okay. Hopefully it comes up. Can you see my screen?
Yes,
Okay,
sir.
let me try to. So let me try to put it in full screen.
Yes.
Can you hear? Can you see my full screen now?
Yes, sir.
Okay, perfect. Let me see if I can move that guy away. Okay, thank you so much, and let's get started. I do have a few good amount of slides, and since this is an FDP on neurodegenerative disorders, I've also arranged the talk in such a way that I will talk a little bit about AI. Wasn't sure if other speakers have covered this, so I'm going to talk a little bit about AI and also a little bit about AI for neuroimaging because that's one of the main modalities used in Parkinson's disease, also across other neurodegenerative diseases. So here is the outline of my talk. Please do interrupt me if the slides are not visible or I get cut off due to internet problems because I can't see any chat or anybody else because I'm in a full screen mode. Okay, so this is the outline of my talk, AI for neuroinformatics. I like to spend some time introducing these models. Of course, for this audience, I think I don't need to go into all the nitty-gritty details of the AI, but I do want to talk a little bit about kind of introduction to deep learning models and how they are have taken over the whole area of neuroscience. In fact, they've taken over everywhere, but neuroscience in particular, because we are talking about neuro disorders. I wanted to introduce the classical image processing techniques, which personally I have worked on like 10 years ago starting, but now we 99% of the time we apply deep learning and AI models. So I wanted to introduce some of those classical image processing challenges. And then I want to shift gears to the original topic of my session, which is on AI for Parkinson's, introduction to Parkinson's, and especially three different type of data from neuroimaging and gait analysis and hand drawing, how they have implications for diagnosis and prediction and also management of Parkinson's disease. And if time permits, I will jump into what Prasad Lab, which is my lab, does here in Cincinnati, what we do in neuroinformatics, especially the same topics of neuroimaging and kind of gait analysis. All right, so let me jump into the first part of my talk. Again, please feel free to put in your questions in the chat. I'm not able to see them, but one of the organizers can probably unmute and ask me questions on behalf of the chat participants. So the first part of my talk, I wanted to go over AI and as well as how it's now used widely in neuroinformatics. So I'll give a kind of a comparison between classical models to how the more newer models from deep learning, invariably neural network type models, have taken over neuroinformatics. So for this part of the talk, I arranged in such a way that I go from basics of deep learning, very fast overview of deep learning, because as I said, I'm hoping the audience know and have applied AI already in their work. So what is deep learning, a primer, and also talk a little bit about neural networks and three important types of models which have chronologically arranged from convolutional neural networks, transformers, and now what are known as foundation models. So I will introduce them. I will not go into a lot of details about them, but there is now a wealth of information available online or books and articles. So I'll just introduce intuitively what these deep learning models are. And then what I want to do is, what can we do with these existing image processing techniques, which are, especially using prior imaging, neuroimaging. And I will concentrate on denoising, super resolution, and fusion and segmentation. Again, this has implications not just in, Parkinson's disease. These are across neuroscience and neuroinformatics. So as all of you are aware, AI wave is currently going on in every data science field, and deep learning is a subset of supervised learning techniques. And as you can see, I've not added any newer references. I've added kind of 10-year-old references because there is a lot of newer or overview and review papers about deep learning which one can find. So deep learning is a subset of supervised learning techniques. This comes under this huge umbrella term, artificial intelligence. So now this AI is even a common term. Even people who are outside the scientific domain are aware of this. And machine learning, is support of this artificial intelligence. And there are two main domains within AI, which is unsupervised learning and supervised learning. And majority of the models which we consider in this talk or also in applied in neuroinformatics are all supervised learning, wherein you assume that you have a large amount of labeled data. So deep learning typically, consists of, successful deep learning models are all supervised learning. There are also unsupervised learning models, which unfortunately I will not be able to cover in the scope of this talk. So in the past 10 years, I should actually put past 15 years now, that a particular subdomain, which is deep learning, has shown tremendous progress. And the recent success can be attributed to, as every one of us know, is that explosion of big data. So now that we have internet penetration everywhere in the world, especially in India, we have a lot of data which is available online, digital data, big data. And also the compute costs have gone way down. So when I was doing my PhD, as I said, I was with Dr. Adler, so that one computer with 8 GB RAM was costing a lot, right? Like now we have 800 GB machines here. So cheap computing costs, which also spurred the development of deep learning models. And of course, the improvement of the machine learning models. By that, I mean the theoretical as well as practical aspects of deep learning models. So this much of the excitement is from a field called deep learning. So I don't want to go and bore you with all the machine learning details, because I do have to go back to neurodegenerative disorders. So I kept one slide which basically has 50 years worth of history of machine learning. So most of the machine learning models you may have seen is based on supervised learning. And this picture is basically like 50 years worth of machine learning in one figure. So let's say you want to try, identify cars from a bunch of pictures. So what you do is that you extract features, which is also known as hand-tuned features or a priori knowledge. About this particular domain, for example, color or shape, and that is known as feature representation. Then you apply some learning algorithm, which can be a machine learning algorithm. For example, support vector machines or k nearest neighbors or random forest. So this is it. This basically was what happening in machine learning world. You assume that about your domain a priori a little bit, and you come up with a set of features. Of course, you can talk about the importance of features, what features to extract, etc. That's the whole domain of classical machine learning. So this has been working really well. I mean, obviously, this is more interpretable because you know which features you're using, for example, color or shape. So this is basically the history of machine learning. This is still valid. People are still applying machine learning for data science. So this has been the traditional go-to way to run machine learning or pattern recognition from the 1950s. By that, you use some fixed or engineering features, or you know some priori knowledge. You encode that and try to extract those features for your data and try to solve your problems in your domain. And you add a trainable classifier. So this is again in the image processing domain. It's very easy to explain that you can have this handcrafted feature extractors which with respect to some shape or color, and hopefully your trainable classifier will learn using that feature space. So where does deep learning differ from this, right? So again, very fast overview that deep learning uses neural networks and what we call a nonlinear feature transformation. So instead of you encoding prior knowledge and features based on color or texture, some particular attributes of your data, you let the neural network compute these features automatically. And if it has more than one stage of these features transformations, then you call it a deep learning. So for example, in imaging, it's again very easy to explain. So this is one of the popular neural network model, a convolutional neural network model used in 2013. This basically spurred the deep learning revolution from 2013. That it uses a series of network of layers of neurons. So each layer has a neuron, but at each layer you extract certain type of feature. So in this case, it can be edges and color. Then as you progressively get more complicated neurons, which compute shapes and features and maybe not interpretable, human interpretable features. So this is the basic idea of neural networks. So how do you come up with which layers, what neurons? These are again are the main topics of the deep learning. So this is basically a trainable feature hierarchy. By that I mean you assume that you have a set of data and you train these layers of neurons. So this is a hierarchy of representations with increasing levels of abstraction. Again, like if I show it in the image, it's pretty easy to understand that initial layer of the neural network will learn some simple geometric primitives like edges, also color primitives like regions which are bigger color or uniform color. And then you go like shapes. This may be like a circular shapes, and then more abstract, it may not be interpretable. So this is again a criticism of deep learning that what do these models compute in comparison to machine learning is not easy. So there is a whole area of explainable AI is coming up. So each stage in this neural network, each layer is a trainable feature. I'll get into that in a minute. And this concept can be applied across data types, so images or speech or text. In fact, in neurodegenerative disease like Parkinson's, we have to use multimodal data like neuroimaging, maybe their speech slurring, and also their hand drawing, which is kind of a text. So applying this neural network is actually very straightforward in that, because it is meant as a general transformation from your data space to this feature space, which is computed automatically. So this is how a neural network looks. Again, I'm not going to go into all the details, except to say that to train a neural network, you let me take the laser pen. You assume that you have a large set of labeled data, so you compute the difference between the network's predicted output and actual output. So you'll have a cost function to minimize. And to minimize this cost function, you use backpropagation so that you assume you have true labels, and you adjust these weights and biases of these layers using backpropagation, using what is known as gradient descent, stochastic gradient descent. And these neurons also apply some activation function before passing the values to the other neuron. And again, you may have encountered very popular activation functions. So I want to shift to convolutional neural networks. So this is a particular type of neural network. Again, here, remember that we are not computing these features a priori or anything. We let the neural networks add multiple layers with tens or even hundreds of neurons in each layer, compute automatically. So in convolutional neural network, instead of just computing using weights and biases as at every point, what you do is you apply a particular type of layer called convolutional layer, which will have a neuron which is a little bit more specific. This is based on neighborhood values, you compute all the neighborhood neuron values and pass it to the next neuron. So you kind of apply a filter based on a spatial proximity. So you can think again, you intuitively, without going to the mathematics of this, that it's like a flashlight representing a single neuron. So in each neuron gets activated by computing neighboring neuron as well. Of course, you can talk about the size of the filter, which is where a parameter you need to fix, like what kind of filters do you use. So this is again very useful in imaging data. People found that our human visual system performs very similar. Our human neurons perform very similarly. We try to group objects together. So that's why in convolutional neural networks are widely applied in imaging data. So coming back to the deep learning, this is how a typical deep learning model is implemented. So here I have given for a neuroimaging data with a CNN convolutional neural network. We are assuming that, let's say you want to segment or classify the brain tumor here. You assume that you have thousands of images with ground truth labels, and you have a cost function, and you put a neural network and try to optimize by changing the weights and biases, and check to see if the output prediction matches with the ground truth prediction, and you try to minimize the loss function. So this iterative way is called epoch, and you run this for multiple epochs or iterations. So this is a typical supervised deep learning neural network method. And again, I'm going to use AI deep learning interchangeably. This is the deep learning model or AI model. So convolutional neural networks have been very, very popular when they started in 2013 and 14, when they won a challenge called ImageNet, where the challenge was to have machine learning models which classify images like this into 1,000 different categories. So in this category, it's, for example, it's an image of a bridge. And one particular neural network, convolutional neural network model, won the top accuracy. So from that moment on, the deep learning wave was started, I would say around 2013. And because of that, convolutional neural networks have been really, really popular. So I actually said this is used in imaging data, but then people started applying CNNs into text and signals and all types of other data types. So this has been a de facto AI model until 2017-18. So in 2017, a newer model came called transformers. So this is based on a paper which came in 2017 called "Attention is All You Need." So this is also based on how our vision system works. When we see a scene, we don't see every detail of it. It's a lot of information to process for our brain. So we actually confine our attention to certain objects. So if you're seeing a scene, you may be seeing the tables and chairs and faces. So the attention is exactly the same concept used to come up with a transformer neural network model. And that was originally proposed for language in translation. But then people started applying for other types of data, especially for imaging data. So again, without going into the mathematical details, I want to quickly finish this AI part. So that transformers are based on, again, neural network. So MLP stands for multi-layer perceptrons. This is basically a particular type of neural network. And you add this encoder where the attention is computed using certain matrices. So you take the imaging input, compute patches out of it because you cannot run on bigger images, and then you encode or compute these attention scores, and then you pass it on to another neural network layers, multiple layers, and then you can predict whatever you want to predict. So in this case, we are predicting tumor or normal from the MRI. So the details of this is again involves a little bit of math, which I will skip, but the transformers are actually the de facto or outperforming models than CNNs in the last 5 years. So transformers work, as I said, I will not go into the detail. I'm going to skip this slide. That they work across modalities. Now they work for signals, speech, text, and imaging. And as I said, CNNs are kind of going out of fashion, and transformers are getting good accuracy that people are actually starting with transformers. So this is a nice review paper came in 2 years ago, and they took a statistics of how many people and what's the state of the art in medical imaging, especially. As you can see, in medical imaging tasks such as segmentation or classification, the transformers are outperforming CNN models. And now, based on the transformers, there is a whole class of models from 2022 or 2021, around that time, called foundation models. So these are all the current models now. So they differ in the one main aspect, the way they are trained. So they are trained on a huge amount of data. So many of you may have already seen ChatGPT or Gemini or text-to-text models, which you may be using in your smartphone or in your work, that they are primarily based on transformer models, but the training has been done using internet-scale data. So ChatGPT, for example, was trained on books and Wikipedia and Reddit and all kinds of textual information. So same way, these models have been specifically transformer-based models have been now trained on huge biomedical data. And now, if you look at any field, you can be, any medical imaging field, there is a foundation model or multiple foundation models are available. Of course, you also have GPT like general models where you can type a question and or upload an image or speak to it, and it will give you answers. So these are all what people are now using also in neuroscience and neuroinformatics. So just to wrap up the AI part of the talk, that this is the next exciting 5 years. It's going to be very exciting. As I said, chronologically, neural networks, convolutional neural networks, transformers, now foundation models, and also generative AI, where you synthetically generate data, has changed a lot of areas, and it's changing neuroinformatics. One problem with the neuroinformatics is that we don't have a lot of resources and data sets. So the answer is that somehow use these foundation models and use generative AI to combine them. So there's a nice review of how these foundation models are there in medical imaging. You can also look at for MRI and CT, head CT and MRI. And you can see that they perform always better than previous standard models. Okay, just to conclude, is AI a magic wand? I would say no. It involves collaborating, especially since I'm going to talk next about the Parkinson's disease, where you need to collaborate with clinical neuroscience folks so that you can interpret what these models are learning. That comes into the explainable AI part, that even if the AI models are now have many benefits, their lack of explanation is what stops them from deployed in the clinical. So in the Parkinson's disease, I will show you some of these exciting AI models which are used now. How do we leverage AI for such neurodegenerative diseases? But there is still a long way to go to really implement in clinics, because especially Parkinson's is an elder care disease. So before I go into Parkinson's, I want to spend the next probably like 15 minutes on how deep learning has taken over in neuroimaging, and then I'll jump into the Parkinson's disease. So I want to talk especially about brain imaging, because they have implications in neuroinformatics, and I want to concentrate on 4 tasks: denoising, super resolution, fusion, and segmentation. So denoising, for example, everybody knows what's denoising, because the images are always noisy, and also in MRI and CT, you don't want the patient to be in the sensor for a long time. So there is always noise, because there is signal versus noise ratio, and you don't want to image the patient for a long time. So you have to have a balance and get whatever image with the resolution possible. So it's a low-level image processing problem that, let's say you have an MRI or a CT, how do you improve the quality? This is known as denoising or image reconstruction. In 2010 decade, non-local means is a popular idea, which is based on a simple image processing concept that if you want to denoise a patch in an image, you use similar patches and compute a weighted average and look at that patch as the denoised patch. So this was state of the art even until 2017-18. Then deep learning obviously started around 2012-13. People have started applying for denoising as well. So this is like a hammer for breaking a peanut. Yes, you're using a huge neural network to solve a simple denoising. But however, these performed way better than previous models like non-local means or any filters you may have seen. So for example, this paper from 2008 and 2016, they used a particular neural network type called encoder decoders, which is again convolutional neural network, and they proved that they're denoising much better in accuracy, and also it can denoise even at highly noisy regimes. So which is again a case in CT and MRI. So if you look at the noisy MRI, you see that there's a lot of noise here, and you want to remove noise without destroying the structures or brain tissues. So the deep learning models have become state of the art in the last few years. Okay, so I want to go to another task called super resolution. Again, like I said, if you take neuroimaging, there is always a balance of getting good images versus the amount of time the patient needs to be in the sensor. So the sensors are always time restricted, the MRI or CT machines. So the image is what you get. So you'll have to post-process to improve super resolution and improve denoising and reconstruct to make it better. So super resolution is the task of assuming a real image, a quality image, but this is how you get the image out of the CT machine, for example, right? So there is a lot of transformations happen before you get the image in your hands. For example, it gets geometrically transformed, blur, noise, and whatnot. So super resolution is the task of improving the quality. So you have to come up with your image processing or deep learning models to go from low resolution images to high res. So when people have been using image processing image processing solutions, they usually use something like interpolations, which again, even undergraduate students know how to interpolate data points, right? So interpolation is like minimizing, some cost function so that you interpolate nearby points and hopefully that improves your picture. So this has been state of the art, until the decades of 2010s. So again, how do you what kind of interpolation you use to improve the quality is what people worked on. But in the last 10 years, that super resolution is also posed as a mapping so that it can be solved as a neural network deep learning based model. So people have applied convolutional neural networks, which is a neural network I showed a little bit earlier, and they use CNNs to improve these low resolution images into high resolution. So this has been state of the art in like last 5 years ago. So I just wanted to give a quick comparison of these are neuroimaging. So obviously they are 3D. For example, you have 3 axes, axial, sagittal, and coronal. And people have also tried to see, instead of applying slice by slice, can we apply neural network based super resolution together as a 3D volume? So obviously, if you use as a 3D volume, you're going to get better results. So if you apply AI for improving, you can actually improve when you do it in 3D. There's also one aspect I want to really mention, which is very interesting, that in neuroscience and CT, MRI datasets, we don't have enough public data. So if you look at natural images, for example, ImageNet has millions of public data with labels. We don't have that much MRIs publicly available. There is a lot of private repositories, but a common AI user cannot access them. So one way to mitigate that is to do transfer learning. You can train your neural network on natural images and apply it directly on a medical imaging. So this is a comparison between natural and also domain specific, like meaning it was trained on whatever amount of brain imaging data we had, and this is trained on brain imaging, but in 3D. So as you can see, if you use domain specific training, it will improve, obviously. So this is again state of the art in super resolution in the last few years. So I want to go to image fusion, which is again very important because when you want to solve neuroscience problems or disorders, you want to use as many information as possible. So a patient may have MRI, PET, or SPECT, or CT. So how do you fuse these to get the best possible information out of all the imaging modalities? So people have been using kind of wavelet transformations or simple fusions, like patch-based fusions, in the last 20 years ago. And it was working okay. For example, here we're using MRI and PET image so that you get both the information of the heat map from the PET and also from the MRI. And this was state of the art until, I would say, until last decade. This also has been taken over by neural network type models. So here is again one very early paper from 2014 when the neural network deep learning era started. They tried to fuse MRI and PET for Alzheimer's. Of course, you can look at Parkinson's as well. So they used a neural network and they proved that it works much better. So they fuse images using deep learning models. So this is again state of the art until a few years ago. Another important problem in neuroscience is to segment brain tissues and on ROIs, regions of interest. People have been using geometrical models for the last a decade ago. You can use for multiple tasks in neuroimaging. But this domain is also taken over by CNNs first. Here's one example of a CNN model segmenting tumors or even stroke regions. You can also try to segment, multiple regions. So this is again, I would say, state-of-the-art models until last few years ago. Now people are using transformers than CNNs. So I'm going to skip the performance metrics. I will share the slides with the organizers so you can take a look at them later. So these are now not the top models. These are all possible CNN type models, but now transformers are the top. So this is kind of an old slide from a couple of years ago. So you can look at MR Brains Challenge, where now if you see that the models are all based on top performing models are all based on transformers. So I'm going to skip all of that. And just to finish how AI has been used in neuroscience and neuroinformatics, especially neuroimaging. So for example, you can, since we have lack of public data, one can start with training from natural images, and then you can apply to neuroscience, neuroimaging. So this transfer learning, I wanted to stress a little bit that that's what pretty much every big model nowadays does, that it tries to train from not just the domain-specific data, it also tries to train from natural images, because we have more millions of natural images than domain-specific data. And people have proven that, even if you start with training from natural images, you can get still good results. So what can we do with existing image processing and deep learning models is what I covered in this part of the talk. There are now well-defined techniques which go beyond by these classical image processing techniques, whether for denoising, supersolution, segmentation, or fusion. They were limited by engineering aspects, but now we are not. These CNNs and transformers outperform all these earlier models, and they work really well in terms of accuracy. Where they fail is that sometimes if you do not have a big data, the neural network models may not work well. And also multimodal AI is where the AI models are going. How do you use multiple domains of data? So that's where there is still a lot of work needs to be done, and also understanding why the model is doing denoising or supersolution or fusion or segmentation perfectly. There's a lot of explainability which is still lacking. And also domain-specific label datasets are not as widely available as natural images. Okay, so now I would like to shift Parkinson's disease. So let's talk about how this AI has been leveraged for Parkinson's disease management. Especially I wanted to talk neuroimaging, because I covered in the last 30 minutes how deep learning has been widely used. And also there are two other aspects of Parkinson's which can be used to which can help us predict and diagnose Parkinson's disease. So which are called gait analysis, especially how the motor movement of the patients, and also the hand drawing analysis. So in the next 30 minutes, I want to go through some of the current AI models which are leveraged for PD, Parkinson's disease. So Parkinson's disease is actually can be studied using multiple angles. So here is a picture of what kind of data types we can expect. So you can have clinical reports. For example, when a patient goes to a hospital, you have electronic health records, neuroimaging, which we saw a little bit. You can also, in Parkinson's, people use electrophysiological data. For example, electrodes implanted on the surface or inside the brain. That's electrophysiological data. You can also have, clinical clinical data, which can be samples collected from the patient. You can have sequencing data, which is like genomic sequencing, and also how the patient walks, the motor movements, including walk, and how the hands, and how the body, and also how especially hands, because you can have tremors, or how do you compute using some activity, for example hand drawing. And also you can have variables, for example like Fitbit, or other variables now available. You can try to track the motor functions using variables. So in the next 30 minutes, I don't want to go into all the AI used in all kinds of modalities. I just want to concentrate on neuroimaging, and also Gait, and also handwriting. So Gait and handwriting are related to how the motor movement happens in Parkinson's disease. So like I said, I'll talk about what's the Parkinson's disease and introduction and stages, how neuroimaging, Gait, hand drawing are used along with AI to predict Parkinson's stages and diagnosis and management. So if time permits, I will talk about what we do in our lab. So here is a general introduction to Parkinson's. So again, I'm not an expert on neurodegenerative diseases, but broadly speaking, everybody knows Parkinson's disease affects the visible effects can be seen in motor skills, and also non-motor skills, which are kind of patient specific. So in terms of motor skill symptoms, the patients, you may see tremors or gait difficulties. There is also vocal symptoms. There are even people who apply AI for voice biomarker, which I will not cover in this talk, but there are some works now. There is also facial expressions changing, but more patient-specific non-motor skills are more difficult to observe. That's where the neuroimaging and other sensors-based things comes into the picture. For example, depression, cognitive impairment can be, discerned using MRI and CT and fMRI. Their sense of smell changes, the sweating myeloma changes. They also have GI symptoms and also joint pain. So, like I said, I'm going to talk only about AI used in some of these modalities, like tremors and motor functions, and also brain-based changes. So this is one of the fastest growing neurological disease. In fact, I recently saw news about India, especially, that our population is growing old. Our birth rates are kind of going down. So we're going to end up with similar situation to Japan, where Parkinson's is very prevalent. We're going to have the fastest growing aging population. So PD is going to have a lot of implications. So using AI for PD is very vital. It's characterized by involuntary movements, especially these are the tremors I talked about, the stiffness, and the patients will usually have coordination challenges, hand-eye coordination, along with the non-motor symptoms. And these provide a window for early diagnosis and treatment. So if you can find the data from the patients and apply AI for it, even with all these visible motor symptoms, there are no effective biomarkers for diagnosing or tracking or comprehensive planning for PD. There are a lot of ongoing works. They are very semi-subjective, and the only clinical validation is the essential one. So we can't, still use AI-based tracking of gait and say this patient PD is improving. So you still have to go back to the clinic to benchmark with the experts. So I want to talk a little bit about the stages of the Parkinson's, that because this has implications in gait and hand drawing analysis. So there are 5 major stages in Parkinson's. So initially it starts with only one of your patient's body is affected. So you may experience a mild tremor. So it doesn't affect daily activities. Then the full body, and then the balance gets reduced. That's stage 3. Daily tasks start to become difficult. And then stage 4 is a little bit more severe, where you need some, assistance to walk and do daily activities. And then, of course, stage 5 is the more severe one. So the idea is to apply AI when the gait starts to change, especially posture, balance, and walking. So there are whole host of biomechanic we know about normal human walking. So can AI identify and treat manage PD using this earlier stages? The better, because then we can try to tell the clinician that, hey, this patient is on the onset of Parkinson's disease. Now we can start, the intervention as early as possible. So that's exactly what the current trend in neuro degenerative diseases, that MRI, gait, and hand ring analysis are used to, kind of predict or at what stage they are in, and also check the severity. Before I talk about AI, I mentioned a little bit about, in neuroscience, AI ready data sets are not as prolific as natural images, because these are patients' data. There's a lot of legal issues to share. Having said that, there are some neuroimaging and as well as gait, as well as hand drawing data sets publicly available for Parkinson's. There are some more newer ones I may have missed. So this table is from a 2023 review paper, but I'm pretty sure there are many other data sets which are available, especially neuroimaging. It will be easier to get. So as you can see here, there are even data sets with genetic information, or gait, or eye tracking, so hand gestures. So many of them will have either neuroimaging or motor-based data. So here MRI, CT PET, and also gait and other data types. So let me go into neuroimaging and how it's used along with AI for Parkinson's. So using neuroimaging for Parkinson's is very important. I already talked about how AI is generally used in neuroimaging, but now we are talking about which imaging modalities are used in Parkinson's disease. So obviously MRI, CT, PET, SPECT are all standard neuro imaging modalities. So especially for Parkinson's, the majority of the studies, if you look at in the last 10 years, which uses AI, they use kind of PET and SPECT imaging, so compared to MRI and PET. The reason is that the SPECT imaging uses particular radioactive tracer, which can detect particular transporters in the brain, which is implicated in Parkinson's. So it can. That's why the trend in the AI world is that to use SPECT rather than MRI and CT imaging in Parkinson's. So here is a quick overview of accuracy across modalities. So compared to MRI, PET and SPECT are as close as to EEG. So EEG is not an imaging one, but rather a signal based modality. So this EEG performance will be always better than neuroimaging, because neuroimaging doesn't have enough granularity to compute the progression of Parkinson's disease. So if you are interested, you can look at Parkinson's Progressions Markers Initiative database, where they have other data types. And if you look at the performance to compute, how much progression of the Parkinson's is there, the SPECT imaging is what people use in the AI world to predict, because it has better information. So here's this table is a little bit harder to see, but this table shows what kind of AI models are all used in and what kind of data used to predict Parkinson's. And you can see that it's around 90-95 accuracy. And if you see, all of the models are all kind of CNNs, although the last 2 years, there are some transformer-based models are used along with neuroimaging data. So here is again overall comparison without going into various AI models. This compares CNNs and other deep learning, deep neural network models. And you can see that the accuracy is not bad, around about 90-95. For example, SPECT, PET, and MRI, and it's comparable to EEG. So I want to go to the gait now. So gait in Parkinson's disease has a lot of implications, as I said, because in Parkinson's, as you go higher and higher into the stages, the more severe your involuntary motor control becomes. So an assessment of motor functions can certainly be used for diagnosis. In fact, that's how clinicians actually stage the Parkinson's disease. And our body stiffness and postural instability gets worse and worse as the disease progresses. And you'll see these gait disturbances. So here is a natural human walking, right? Like this is how we usually walk. So this is from the world of biomechanics, where when your heel strikes the floor, that's your initial contact, and then you start the next leg, and you do this cyclic motion to walk, right? So there's a lot of well-defined terminology, and this whole cycle is called gait cycle. And there is a stance and a swing, and there's also a region where there's a double support. So these terms are used and also computed from the normal gait. Now, if you have a Parkinson's patient, you can try to see how much deviation his or her gait has on this normal gait cycle. So that's exactly what the AI-based models are looking at, to look at how the gait is changing. So here is the clinical criteria of how gait and movement analysis is implicated, and how worse it becomes as the time progresses. So if he can have an AI model looking at the gait data, I'm going to talk about what kind of data it is in a bit. Let's say you have, video data or pressure sensors in a biomechanical lab. If you can have an AI which can detect way before you get Parkinson's, that can help the clinicians to map out your next 10 to 15 years so that you can live comfortably. So in Parkinson's disease, the earliest you can try to find is, so this is the diagnosis time point. So at that time point, your upper limb movements, your gait asymmetry has come. Your gait is not like the normal human gait. You already see some differences. So if you can predict, 5 years, 10 years, or even 15 years, that will be really valuable for the patient. So this timeline is very important. So as you can see, around about 5 years, the asymmetry of your gait starts to manifest. By that I mean you can visibly see that Parkinson's has affected your gait, especially in symmetry. And these are early symptoms after your diagnosis. And then as it gets more severe, mild to moderate, and late, you may get a risk of falling. You may need assistance to start walking around, or you may even need a wheelchair. So if you can try to use data even when you are normal and see, is it changing? Can we detect any gait pattern changes? That will be really useful. So that's what the Gait AI models in Gait try to do. Okay, so let's look at AI models which are currently available for gait analysis in Parkinson's. So typically these models involve 4 main steps for analyzing your gait. It can use wearable or ambient. By that I mean video cameras. So in one of the projects I'm going to show later in my lab, we used standard cell phone video cameras to predict gait changes. And also you can have hybrid systems where you can have wearables plus pressure sensors on the floor, or video cameras. And so you need to have a collection of sensors, and you need to have some protocol so that the normal test subject or a Parkinson's subject can do certain tests like walking, sitting, and standing, etc. You collect the data set, and then you extract features either using machine learning or now like I said, deep learning models which compute all these features from the census data, and then you can apply your classifier. So this is again not just for Parkinson's, Alzheimer's and other neurodegenerative diseases. I'm pretty sure other speakers will cover some of these other diseases. So Parkinson's especially, because it's your walking speed decreases, your stride length decreases, your swing time decreases. You will have higher double support time. So if you go back to the picture, you may spend more time on the double support. So we can try to use that to differentiate between normal versus your Parkinson's. So that's why this gait characteristics is very important, and that's exactly what the AI models are trying to exploit. So gait analysis can be done with, now I come to data types. You can use wearable sensors. Again, wearable sensors are a little bit easier because it's, think of like a Fitbit watch, because they have a gyro and you can try to predict things. Non-wearables are even more better because then you don't need to interfere with the patient. You can have floor sensors or stereo cameras, or even infrared thermography or normal video cameras. So if you look at gait analysis and AI in the last few years, you can see that this is a performance comparison and kind of around about 10, 12 papers from this older review paper that CNNs are widely used, especially with the non-wearable data, and you can see that the accuracy close to 95, 98. And what is the objective here using these AI models is that can we predict and give real-time feedback and make sure they can go to physiotherapy or life improvement with clinicians. So the idea is to have real-life data and apply AI, and you can monitor the movement and give a feedback to the patient and customize your exercise, and then you do this in an iterative way to improve their lifestyle. So if I go back to the table I had where I talked about what kind of models people are using, especially in Gait. So you can see that these are based on either 1D signals or a floor sensor based biomechanical lab based data, or ground reaction force. But now we can also try with video cameras because the AI models are getting better in processing videos. So the recent models are using not just these wearable and non-wearable data, they're also using video data. So next I'll jump into the handwriting part. So you can already see in this table that majority of the models are based on convolutional neural networks. So I also wanted to mention that although I talked about Gait is measured using wearables or non-wearables or video cameras, there are other ways you can try to collect data. One recent trend in the field in Parkinson's is having home devices, because remember these are patients which are older patients, right? Like bringing them into a biomechanical lab and making them walk is very time consuming and also not comfortable for the patients. So can we have home devices? So again, think of like IoT and smart sensors. So this is a work from a group from Stanford in 2022, and they're still working on a few more sensors. That this device emits a radio wave and it detects backs of the people's body, so it infers the gait speed as they live in their home. So it can track the trajectory, it can track the severity of the gait, and hopefully it is good enough information to use. So this is not exactly like a wearable or non-wearable, but it's more like a device, ambient device on your home. So let me shift to hand drawing analysis, because again, this is one of the common non-motor, common motor symptom which you can use to infer Parkinson's. So why hand drawing analysis, right? So we all use pen and paper. Actually now we use smart devices. We don't even use pen and paper anymore, but the majority of the PD patients have handwriting abnormalities, right? So this is known as macrographia, abnormally small letter size, and this is the most commonly reported and easily detectable handwriting abnormality. So here is one example from a normal patient. So the patient was asked to do a circle drawing motion, and as you can see, it's, the patient has done in a very smooth way. And the last column, C, is from a Parkinson's patient. So the difference is kind of visible, that because he or she is not doing a smooth motion. And this one is actually from a paper which is based on a drug used to treat mild Parkinson's. So they are showing that after the drug is taken, the patient is getting a little bit better. But when you compare to the normal hand drawing, you see that the Parkinson's hand drawing is way different. So now can you use this data? Like you let the patient draw and you take the images of that and apply some AI models. So that's exactly what people do. And handwriting abnormalities can be done in two different ways. People usually observe in clinical. You go to a doctor and he observes you drawing vertical or horizontal. Is it consistent or progressive? So if you see that vertical, and how do you do horizontal smoothness? So this is a normal patient's normal controls drawing. The same thing you can do by digitized handwriting. So you can let the patient draw and digitize that handwriting and try to compute certain features from the handwriting uh, signal and see if your AI can detect. So here is again an overview. I don't want to go into the details of all the AI models. So there are 15 to 20 papers which use handwriting analysis to predict whether the patient has Parkinson's or what stage the Parkinson's is in. And as you can see, many of the models are all based on CNNs. This is again the same table I had previously, where now the handwriting, I want you to concentrate on the handwriting analysis. And as you can see, almost all the models are all CNNs. In the recent years, people have started applying transformers, but we have not seen yet a transformer model applied to handwriting analysis. The reason is that this handwriting data is not publicly available. Very few data sets are there. Okay, so comprehensive management, right? So despite all this, neuroimaging, MRI or PET SPECT or Gait or handwriting to analyze motor deficits, few of these approaches are accurate, actually. The reason is, I mentioned at the start of this part of the talk that, we are only talking about neuroimaging and motor. How about other data types, right? So a patient's journey is complex and multimodal. So you want to use as much information as possible. So there is a need to comprehensively use data sources. So you can collect clinical assessment and neuroimaging, obviously, and electrophysiological assessments, if possible, fluid and tissue biomarkers. You can also do genetic testing, which is becoming cheaper and cheaper. And of course, you can do Gait and handwriting. And also you can, wearable device, which is also getting cheaper. So what we want in applying AI is that, I showed papers applying AI separately, either using imaging or Gait or handwriting. How about applying it together? So I think that's where leveraging AI will be more powerful, that if you can get all possible data for the Parkinson's disease, then you can try to do a comprehensive Parkinson's disease management. So of course, there are some papers in AI using electronic health records or electrophysiology data, but we could not find many papers which combine everything into one. So AI's implications in Parkinson's, that now everybody is aware of AI, starting from life's conception all the way to the elder care. So why not have a digital twin where you try to collect as much information as possible from the Parkinson's patient, or even before Parkinson's starts, you collect this digital twin of yourself, and hopefully it will give you a warning, hey, your gait is changing, your handwriting is changing, your speech is changing, so you're going to get Parkinson's in 5 years. So then you can start treatment as early as possible. So this is kind of self-driving medicine. A lot of people are thinking that the world is moving towards self-driving medicine, meaning similar to self-driving cars. Hopefully we'll get conditional automation where you input all possible data about you, and this big AI model will predict where and when you are in your life journey. So hopefully, just to wrap up and go to a couple of my projects in my lab, that I gave a overview of AI in neuroinformatics, how AI has taken over in neuroimaging for different image processing tasks. And I also talked about Parkinson's, especially neuroimaging, Gait, and hand drawing. And I stressed that we need a multimodal AI approach, which is currently lacking. And I want to go, since I have time, I'm going to go and showcase what we do in the Prasad lab. So our lab is a biomedical imaging informatics lab, and now it's a multimodal AI lab. So we have a wide variety of students from different backgrounds, from biomechanics to electrical engineering to computer science, computer vision. We use all kinds of resources. That's why I was stressing about multimodality, that disease is not from one modality, right? Like it's not just from MRI. You have clinical data, you have biomarkers from, clinical biomarkers like blood and urine. So we use all kinds of data possible to do diagnosis, and especially, in a disease case like Parkinson's, you want to use as much data as possible. So we use AI across the models like machine learning to current transformers we use, and we also apply to other data like clinical genomics data. We are a collaborative lab, so I'm going to skip this slide. If you're interested, you can email me. So I want to go to what we do in neuroimaging. So As you can see, our lab is based on a pediatric hospital. So we don't do Parkinson's disease, but we do very similar things for other diseases, neurodevelopmental disorders. So one project I wanted to highlight is predicting microbleeds and stroke from CT imaging. So we applied CNN models for finding out hemorrhage, which is basically bleeding. So we are extending this to include transformers and trying to predict the ranking score, which is a particular score for a stroke. And we are trying to combine multiple different data types, not just imaging from CT. We are also trying to combine with clinical data to predict the stage they are in, disease stage. So I'll skip the results and then I'll go to the other project. So this is again a very interesting data type. When you have cancer, usually the tissue biopsy is taken. It can be any cancer. So in this case, I'm showing brain tumor. So the tissue biopsy can be used to predict, the disease stage. So in this case, we are using AI models to, from the patches, from the images and some EHR, electronic health records, to predict what stage you are in. So we are using, again, similar convolutional and transformer models. So explainability, I talked a little bit. In this imaging data, you want to know what the neural network is looking at. So here is one example of where the neural network says, oh, these are the regions which corresponds to more severe brain tumor. So you can see some kind of a gradient activation maps. And of course, we got around about 85, and we are currently working on improving by adding other imaging, other modalities like RNA sequencing data and genomics data. So I want to go to Gait. Although this is not for Parkinson's, this is for neurodevelopmental, meaning earlier stage for kids, pediatrics. We are looking at cerebral palsy and traumatic brain injury. Our aim here is very similar to Parkinson's. We want to estimate how the gait has changed. So we also wanted to do this without any wearables, without any biomechanical lab setup. So we are actually using cell phone cameras and see if we can extract. And we use AI models. So we use something called OpenPose. This is a very old model now, 5 years ago. This model is based on a convolutional network, I think. So it's real time. It can detect the skeleton, and using the skeleton, you can extract some statistical values and then see if your gait has changed. So that's what we did in our project. We are currently doing more advanced models, but as you can see, the patients are all smaller pediatric patients. So we are looking at how, for example, the left leg is changing. So we are trying to combine this with other comprehensive management I talked about in Parkinson's, like how do you combine gait along with neuroimaging and clinical notes and try to see if their gait, or if their if you can change their gait and make their life easier. Okay, so just to wrap up, what we do here is very similar to Parkinson's disease, that we are benchmarking and trying to identify gait changes. One advantage with the AI models now is that these AI models now work for videos. So you don't need a very sophisticated setup. You don't need to go to a biomechanics lab. You can just use in your home, take a photograph or a video. So this is, for example, a cell phone camera. We were able to extract the gait, and even if you use open source AI models, it works really well now. And you can compare with the ground truth motion lab data. All right, so why we do this? Because it's very similar to Parkinson's, that if your gait is changing, that means there is something wrong with you. Or if your gait is already changed due to certain disease like cerebral palsy, how do we correct it? You do therapy sessions and try to correct. So you need to compute this gait so that you can correct and make a report out of that. All right, and finally, EEG. I did not talk about EEG at all. Now, EEG is again a very popular modality, a little bit easier than neuroimaging, because EEG is kind of on the cap. EEG data. So people are using this for Parkinson's, and we recently undertook a survey of how people are using EEG. We found that people have still not used state-of-the-art AI models. People are using older models like LSTM, which is long short-term memory, or convolutional neural networks. We found that there is sparsity of transformer-based models in EEG. So I will stop here because I think I'm kind of getting over to the time limit. And I'll stop here and say thank you. And I'm very happy to take questions at this time. Thank you.
Thank you, sir. The forum is open for discussion. If you have any clarification, participants, either you can unmute or you can ask.
Can I provide some information related to LLM model? LLM?
Thank you. Yeah, that's a great question. So unfortunately, I did not had so I did talk a little bit about, let me go back to the conclusion slide. The question is, can you talk about, LLM and ChatGPT style things?
Yes.
So in fact, yes, yeah. So I did mention about EHR data, right? Like if you go back to, let me go back. So I'm hoping you're asking with respect to Parkinson's, but I'll try to answer in a general way. So the clinical assessment is available, right? Like, I mean, EHR data is always there. There are people who are looking at ChatGPT test style using text data from the patients. So there are some works, but unfortunately what we found, we recently undertook a survey, right? Like I told you about EEG survey, but we are also looking at what type of data people use in Parkinson's. There aren't many works which use clinical data, text data, but that is a great question. If you have the data, right? Like now the Gemini, ChatGPT, they've come up so well, you can just upload the report and it will predict something for you. This has been applied in other neuroscience domains. So in our project, we are using clinical text data as another to predict. But in Parkinson's, not many works are there. In fact, I would even say that there aren't any work which is using EHR data. But that's a great question. So yes, it's a you can use ChatGPT and LLMs to predict. Yes.
I have one more doubt. Just presently, suppose I have feature matrix. CNN, I directly given to feature matrix all the layers, or I cut down some layers and directly given to some. No.
Yeah. So that's again another great question. So can you do feature selection? Is that what you're asking in CNN?
Yeah, already feature matrix is there. Listen, nowadays CNN for automatic feature extraction, but already I have feature is there.
Yeah. So the question is, if I have some a priori features, can I use them somehow? Yes, you can. So in fact, if you have your own features, you can kind of concatenate along with these convolutional features, and it will improve your results. So in some of our projects, we noticed that we tried convolutional features and we tried our own features, like anti-tune features. When we combined them, it performed much better than either alone. So yes, if you have other features, you can combine them and try to see if it improves your results, right? So like I said, this neural network models, CNNs, or even transformers, they compute all those features inbuilt, right? Like you don't need to do anything. But if you know domain-specific features you computed, and you know for sure it will improve. For example, in Gait, you know the step size is an important feature. You compute that feature, add it into your AI, it will improve your results.
Thank you.
Yeah.
Sir, normally in the Gait signal, especially in vertical ground reaction force measurement, we measure swing stance and stride period like that by taking few cycles and we calculate. In the recent work, you said without even using neither a wearable device or non-wearable device, the recent work. How actually, for an elderly person, how it actually works? Could you please elaborate?
Yeah, no,
recent work you have shown.
Yeah, that's a great question. So the question is about, I talked about, you don't need a special setup. For example, in if you can see this video, this is actually from a motion lab. There is 4 sensors at the bottom. Of course, we are not processing any other data. We are only processing this front video we took using a cell phone. So how can we adopt this for Parkinson's? So the Stanford group I talked about, they actually released some data, video data, which you can use. And also these models are all open source Gait models. So now these models are, even newer models are working flawlessly. Even if it's a video from very low res cell phone, your camera is moving around, you can still extract this skeleton, right? So To answer your question, it is possible. And if you look at the last couple of years, even in elder care, people are using videos because it's much easier than having, like I said, sophisticated setup like motion cameras and things like that. So if you are interested, please email me. I'll send you the correct resources. There's a lot of elder care groups. They are using video data because extracting this gait is very easy nowadays. The skeleton, you can even do 3D avatars now. The newer AI models can take a single image and create a 3D of you. Now, if you have a video, it can actually, unfortunately, I don't have a slide for that, but there's a recent work where it's not just for kids or adults, any human body. There's an open source model which you upload a video, it gives you the 3D avatar. So now you can do all kinds of biomechanics on it, right? You don't need any sophisticated setup. So you can tell your patients, hey, just take a cell phone video. Maybe you can have a protocol like, hey, take from front or side. The more you control, the better it's going to be. Obviously, the like variability. Like for example, this person in the frame is our model is computing her gait as well, right? So you can tell them, hey, walk around with a clean background. Your AI model will pick up even better. So we found that this was like a couple of years old work, but now newer models are even better. You don't need any sophisticated setup. You don't need, like for example, this session costs the patient like $700 to go and do because that's a therapist doing it. But now we have told them upload your video from your home from a uniform background. So yeah, I'll send you some links if you can email me your questions.
Thank you, sir. Sir, you told about digital twins, right? Digital twins. So, what may be the role in early diagnosis, or what's the actual application? Is it used now in real time?
Sorry, what was the last question?
Is it used now in a real-time clinical?
Yes. Okay. So thank you. So the question is about digital twins. Okay. So probably I kind of hyped it up. So we aren't at that level yet. I mean, probably in developed countries like US here, for example, that's where we are going towards. Where because I'm at a children's hospital. When a children's hospital encounter happens, we already have detail from their physician, the primary physician, that his or her doctor. So we have the data. Sometimes we take urine test or blood test, all those things. So our system is actually kind of digital twin already. We have everything in one place. So you just need the patient number, the MRN number. We can pull all the data. So what I meant here as a concluding thought is that even in developing countries like India, right? Like now you can access your data. Like for example, you go to the hospital, you take an MRI, you can request your doctor, give me the copy of the MRI, right? Now you can collect all of them digitally, right? Like you can have, especially this audience is all AI, all audience which are scientifically oriented. You can collect your own data. So for example, I have my MRI, I have my sinus MRI, I have my CT, I have my EHR data I downloaded. So you can create your own digital twin. That's what I mean. I mean, I'm kind of, hyping up, like, for every person, you try to collect as many data, like family history, you can have medical history, you can have, if you have taken some sequencing data, because sequencing is very cheaper nowadays. You have, like, for example, I have a Fitbit, so I can download an Excel sheet of my walking, sleeping, all those things, right? So that's my digital twin, right, basically. So right now, at advanced countries and advanced labs like us, for a patient, we try to take as many data points as possible, imaging to genomics to healthcare records. That's what I mean by digital twin. So we are nowhere close to creating a proper digital twin, but we are getting closer there. I think end of this decade, for every patient, we will have everything in one place. So we are already having as many modalities as possible. Sometimes the systems do not talk to each other, but those problems have been solved as we speak. So for every patient or for every human, we should have a digital twin. That's my kind of a eye in the pie in the sky dream, that we can have our digital copy, because then you can do all kinds of analysis on that. You can even say, what will happen if I get Parkinson's, right? Then, I mean, in the in silico digital twin, not in your real life. So, right. So that's why the digital twins is getting popular. The concept is that you collect all possible data about yourself, and you can do perturbations on it. what if I get this disease, or what can I do? What changes should I do in my physical activity? What kind of medication changes should I do? You can simulate basically all kinds of scenarios. Yeah, that's a great question. Thank you.
Sir, is there any exoskeleton gait analysis in your laboratory?
What written? Sorry.
Exoskeleton gait analysis.
So yeah, the question is like, do we do exoskeleton gait analysis? Yes and no. So what when we started this
Kind
project,
of
the
braces or something for the people who
yeah,
can't be able
yes.
to.
Yes. That's a great question. So the question is, do you use any exoskeleton things? Yes and no. So the S part is that if you see these videos I'm showing, they are actually from Motion Lab. They are actually they have these markers on their body. So they are kind of exoskeleton based tracking because we want to benchmark with their camera. So if you see this on the top, they are the specialized motion tracking cameras. But what I'm showing is only based on OpenPose AI model, which is a public open source model. We just uploaded the video and it gave us this without any exoskeleton or anything. But to answer your question, yes, you can also track with exoskeleton. In fact, all the 3D effects or Hollywood people, they're all using this AI-based tracking now. So as you can see here, these are trackers from the Motion Lab. But there are some videos I showed in the next slide here. So this is a video where there is no marker or anything. So even with this, the AI model is able to extract. But the top two videos are actually from the Motion Lab, and the patient is wearing the dots, which are tracked by these high-resolution cameras. But my point being that you don't need any such high-resolution things. You just use your cell phone and dump it to OpenPose, and it will give you the skeleton.
Thank you, sir.
Yeah, you're welcome. I couldn't see the chat. Was there any question in the chat? Let's see if I can. I don't see any. Okay. Okay, I do see a lot of chat questions. So apologies, I couldn't see.
For innovators, which one you suggest AI-based solution for AI-based solution or DBS or FUS?
I am not
Deep
aware of
brain
DBS.
simulation or
Oh, the
focused ultrasound?
okay. So unfortunately, I'm not an expert on deep brain simulation or TDCS. I've read about them. I would say AI-based solutions, primarily because, like I said, the AI-based solutions, right? Like even with just by uploading a simple cell phone video, you can get a lot of data. So if you talk about deep brain simulation, you need to have the patient in your lab, put all those caps. It's all discomfort, time, compensation. There's a lot of factors involved in getting a patient a DBS, right? Like, so I would say these are non-invasive models. You can also, the models are all public. You don't spend any money. So if you look at, so let me go back to the OpenPose. So this is actually a very old model. I think this is from Google or Facebook. If you type OpenPose in Google, you will find out. So I would suggest to go for AI-based models because try to see what you can do non-invasively before you try to do. Okay, DBS is not invasive, but still you have to put a cap or something. Like even EEG is kind of discomfort, right? Because you have to add a cap and electrodes and the sensors and electricity and whatnot. So this is no expense, right? Like everybody has a cell phone camera. You tell them to take a video and then you can just extract and see if it can give you good information. For example, what we do is to how much the gait symmetry has changed. So we did a very simple algorithm where we cropped this patient skeletons, took the skeletons, brought it in the same coordinate frame, and we put a straight line down the middle and checked for symmetry. And we found that their symmetry for a certain cerebral palsy subgroup, the symmetry is changing. And we are now currently testing it with the clinician to see after you do the therapy for a few more months, is the symmetry coming back or not. That's a great help for the clinician, right? So, I mean, try AI fast before you go to DBS or because again, I'm not an expert in DBS, but I don't know the long-term effects of deep brain simulation, right? Some people say there is good things, but I'm not an expert to talk about DBS. So I would vote for AI. Okay, so yeah, collected non-invasively. Yeah, sure.
Thank you, sir, for your comprehensive coverage of Parkinson's diagnostic method, starting from non-motor to motor, covering MR images, guide signal, handwriting analysis, starting from basic model of CNN and LSTM and covered up to transformer-based model. Thank you for your innovative session, sir. Thank
Yeah,
you very
thank you,
much for
Dr.
your acceptance. Thank you, sir.
Yeah, thank you. I will give a link to the slides to Dr. Adalasan. Please feel free to share. It's all public, so participants can look at it later. Yeah, thank you.
Yes, sir. Thank you, sir.
Thank you.
Thank you,
Bye,
sir.
Adal.
Dear participants, thank you very much. We will see tomorrow at 6:30.
Thank you. Thank you.